short talk is about hydrozone and EBOO for avascular necrosis of the femoral head. We all realize that AVN or avascular necrosis of femoral head is assuming epidemic proportions post COVID and COVID vaccines. Most of these patients are advised total hip replacement irrespective of their young age. We all know that hip replacement is accepting or failure. Hydrozone is a combination of molecular hydrogen gas and 100 micrograms per ml of ozone. These two are injected, first 5 ml of cocktail is injected into the hip joint, followed by hydrozone to cause arthrodiastasis. The cocktail is nothing but pentadiluted xylocaine, 20 micrograms of clonidine and 0.5 milligram of kinacot. IAOS latest EBOO is plastic renal filter free 100% ozone compatible system. EBOO is not dialysis, and as per IAOS belief there is no role of renal filtration or dialysis machines or the plastic filters. Filtering blood with cellulose triestate filters or polynephron filters has nothing to do with EBOO. EBOO is simple extracorporeal blood oxygen ozonization. Filtering blood proteins, throwing liters away and calling them waste is absolutely unscientific. Real EBOO is 100% absorption of all ozone administered into the blood and ozonizing the entire blood volume of the patient to the tune of 70 to 100 micrograms per ml of total blood volume. Filtering the blood with fibrils, rushing low concentration ozone across membranes, using destroyer at the other end, and hoping that the blood is properly ozonized to high concentration, which is currently marketed, is wrong. This video shows the complete steps of the real EBOO, where 400,000 micrograms of ozone are diffused in the blood of a patient. This is a patient of avascular necrosis post-COVID, and at the end of the talk I am showing some results of my previous patients. The first step is to lock the lower lock of biwall so that there is no gaseous escape. We take 20 ml of hydrogen and 20 ml of ozone. The hip joint is approached anteriorly. The Chennai cocktail is mixed. Pentadilution means dilution 1 in 5. This means we are taking 1 to 2 ml of xylocaine, adding 0.5 milligram of kinacot or depomedrol, diluting it to 8 or 10 ml. 5 ml will go into each of the hip joints, and the needle is not withdrawn through the very same needle. We are injecting molecular hydrogen and ozone. This is also called ozone arthrodiastasis. The patient feels expansion of the hip joint and relief is rather dramatic and early. I do not do this procedure in operation theatre, nor do I take the help of a C-arm image intensifier. because I believe that this unnecessarily prolongs the duration of the procedure and increases the financial burden on the patient. Once the cocktail is connected in the syringe, it is closed, capped and kept aside. The needle will be changed at the time of final injection. So at this stage I am searching for the needle. We have located it. Now we have changed and put a new needle. After this, hydrogen and ozone are extracted in their respective syringes. Ozone has to be drawn in a ozone compatible rubber free syringe, whereas no such rules are applicable for hydrogen. So we connect the hydrogen, which is bubbling at 600 ml per minute, and this gradually fills up the syringe. Once it fills up the syringe, it is kept upside down and the lower lock is locked. We press and see that the gas volume is present and available. We now keep the regulator at the appropriate speed, appropriate level, and we will fill up a 10 ml syringe with ozone. We wait for the smell of ozone before filling up the syringe. This is again connected to the bivalve, and so now we have two syringes at right angles and the gas is locked and stored into place. This is held by the assistant. We have switched off the machine regulator and we start injecting the hip joint. The joint is approached, we aspirate and see, and then we inject about 5 ml of the cocktail. This is followed by hydrozone injection. You can see the long needle that has gone right up. First step is hydrogen is injected, and next step is ozone is injected. We now lock the syringes. Once again, we change the needle and approach the other hip, again anteriorly, anterolateral to the neurovascular bundle. We can always find the hip capsule if the needle is long enough. Sometimes in thick capsule, penetration may take effort and pushing does cause effort. We now again connect the syringes and first give hydrogen and then give ozone. Hydrogen injection is pain free, ozone will cause severe pain, but because we have given blocks beforehand, this sequence makes it painless. We are now checking on the veins, the visibility of veins and whether the veins are good. This was a vein finder which I was wanting to use. However, this patient has got absolutely lovely veins, and this vein finder and pen is only a demonstration to show you that it is practically useless and worthless piece of equipment. We need to locate the vein by our look and feel, and we have decided not to use the vein finder for finding the vein. We have got a very good vein clearly visible there. Next step is to check the perfusion pump. That has been kept at a speed of 8. The pump can be changed to clockwise direction or anti-clockwise direction. We have to evaluate the flow, checking from where it is coming to where, and then either keep it in clockwise direction or keep it in anti-clockwise direction. Pump is switched off. Next, we take a 500 ml of saline. Heparin used here is 5000 units per ml, 5 ml. Of this, 4 ml, making it 20,000 international units, goes into the saline bottle. And the remaining 1 ml, making 5000 units, is mixed with distilled water and kept aside for flushing and other purposes. At the end of the procedure, the amount of heparin used is very, very little. So 4 ml has been extracted, the needle has been capped and kept separately. This will be used for drawing later. A thicker needle is taken, and this heparin is now pushed into the saline bottle from the top. Bottle is shaken so that the heparin is uniformly spread. That is left behind as an air vent. Now we take the remaining heparin, which is just 1 milliliter, and to this we add 4 milliliters of distilled water and cap it and keep it aside. The steps have been described in the book and also is shared on the EBOO group along with other finer details. So here we have mixed the syringe and kept it. This is the EBOO flask. So the top end is from there, the filter goes in. After removing the cap, using a straight artery forceps, we remove, which is sterile, we remove parts of the cap to expose the small opening, the larger opening and the plus. Into this opening, the steel spike will go. Into the opening besides it, the smaller opening, the waste outlet will go, and into the center of the plus, ozone will go. Ozone will travel through the stainless steel tube and bubble from the bottom. No destroyer is used, which means the absorption of ozone is 100%. In renal filters and dialysis mode of ozonization, less than 20% ozone goes into the blood. Here, nearly 100% goes into the blood because the room does not have any smell of ozone. Once we have opened the top and bottom, UV hanger with stand is hung on the same stand, and the bottle is inserted into it. Next step is priming the donor set. The donor set is very simple. The new modified donor set has a long steel spike to go into the bottle. a three-way to go to the patient's cannula and the bulb that goes into the heparinized saline bottle. All coilings are uncoiled. The sharp spike of the bulb is inserted into the heparin saline after locking and closing the flow set. The set is now primed, and then we are going to flood the donor set with this heparinized saline to coat the interior, both the silicone part and the part belonging to the heparinized saline. So you open the heparin and allow the diluted heparin saline to flow through and wait till it streams out to the bucket. Once we are sure that it is well lined and well primed, we are ready for injection to the patient. The steel spike is pushed into the EBOO flask through the large hole, and this is to be at a significantly lower level than the waste pipe, which is at a higher level. So now we have got the waste pipe. This waste pipe is pushed into the smaller circle. Lastly, so we can see the height difference between the waste and the steel spike. Lastly, we will push the needle into the tube through which ozone will be diffused and bubbled. We ensure that the needle is in the stainless steel tube, and then the same is put into the hanger. The pipes are put up, the bottle is ready. Now we have to attach or insert the pipe into the machines. First, we locate and ensure that the ozone pipe is located, and that goes into the ozone machine so that it will bubble the ozone into the bottle. Then comes the perfusion pump set, and this one is put into the pump. IAOS tubings, the entire length is pump compatible, disposable, and so it can be fixed at any level into the perfusion pump. We test the direction of flow by switching on the machine, and we can see that at the low speed already the heparin that was used to prime and flood the tubes is dropping into the bottle. It is now closed, and the recipient part is attached to the bottom of the flask. This recipient is gravity dependent, and so we do not need complicated air vents or traps as is used in the filter system, which is popular the world over. The output is closed, locked, and the set is hung besides the EBOO flask. We are all ready to start the procedure. The clocking of the time starts when the actual ozone is bubbled. The vein is located, an 18 gauge venous cannula or venflon is used. Once the cannula is in the vein, it is pushed in, and now we connect the tubing to the cannula. Before that, it is anchored, the vein is closed, clamped to avoid reverse spillover, and the pump connection or the three-way is connected. Now, once the pump is started, the blood starts flowing up. We can increase the speed to about 18 ml per minute. We can even further increase it later depending on the vein and the status. Very low quantities of heparin are started, and a mixture of heparin and blood is being drawn by the perfusion pump going into the EBOO flask. At this stage, ozone has been already started and has started bubbling into the flask. We have kept the regulator at 1/8 and switch 9, which is giving 100 micrograms per ml. So from now on, the timing or the clock starts, and we would be ozonizing at the rate of 100 micrograms per ml of blood with a flow of 1/8 of a liter per minute, meaning that in 8 minutes around 1 liter of oxygen or 100,000 ml micrograms per ml of ozone are administered to the patient. Now is the time to locate the recipient vein. If the patient's veins are not good, we can even use a smaller cannula. Here the patient's veins are good, so the 18G cannula is good enough, and we can comfortably enter the same. Once it hits the vein, we withdraw and then we push it in. Now we are ready with the recipient site. We open up the recipient connection. The tourniquet remains on in the donor site while it is taken off in the recipient site. The recipient site is primed. You can see the bright tomato red color of the ozonized blood. No filtration. It is just blood ozonization. Extracorporeal blood oxygen ozonization. See, it's like arterial blood. Now it is connected to the recipient venflon, and the process of EBOO commences. The color difference between the inflow venous blood admixtured with heparin and its post-irradiation and post-ozonization look of bright redness is strikingly remarkable. The duration of the procedure depends upon the amount of ozone we intend to administer to the patient. You can see the difference in color between inflow and outflow bloods. The rule of thumb is 70 to 100 micrograms per ml of the patient's blood volume. Once the desired duration has crossed. The steps are simple. Tourniquet is opened, machine is switched off, heparin is closed, inflow is slowed down, we disconnect the donor site vein, and now we start the pump and increase the speed of the pump so that all the remaining blood in the tube is pumped into the EBOO flask. All this while ozone is continuing, and ozone will continue until the blood in the flask recedes to the level of lower 1/3, lower 1/3. So now you can see that the entire blood in the pipe is removed, the bivalve is closed, the heparin saline part is discarded by detaching the tube from the bivalve, and the tube part goes into the waste bin to take in any excess foam or waste that comes into the bottle. We can see that the total amount of waste that has been generated is less. The waste or foam generated depends on patient to patient, and in this case it is not significantly large. The bright red blood continues to flow into the patient, and once it has reached the lowest levels, the ozone is switched off, the regulator pushed to 0, and the last amount of blood is allowed to re-enter the patient after switching off the ultraviolet lights. The procedure is performed in a therapy room, and without much ado, we wait till the entire blood is transfused to the patient, and once it has reached the level of heart, the tube is blocked, the transfusion set is disconnected and plugged. In case we are planning to use the same for nutraceuticals on the next day, we will leave the Venflon on. The X-rays now shown subsequently belong to a different patient but show the extent of results. This patient whom we have seen was done recently, so it will take some time for the results to come. The protocol deployed was always repeatable and constant, cocktail inhib, hydrozone arthrodiastasis and Mukherjee regime for 18 months. You can message me personally to know about Mukherjee regime, pre-treatment X-ray on the left and complete revascularization of the patient with absolute full function and joint space retained, pre-treatment showing large cavities on both heads, impending collapse, and post-treatment after just 12 months or 18 months to see that the entire head has revascularized to normal without core decompression, and of course no question of hip replacement. So the X-ray can both pre and post can be compared. You can see the impending collapse and you can see complete revascularization. For more details about the procedure or the equipment or the courses, please WhatsApp the above number. No voice calls, WhatsApp messages only. Thank you very much. Thanks.